Good morning. My name is Matt Murphy, and I'm giving a talk today titled, What is Good PRP and Why? I'd like to thank the organizers at this conference at the Advanced Regenerative Medicine Institute and Drs. Rosenthal and Cheng Chen for the invitation to speak on this interesting topic and share my thoughts on the subject. First, I'd like to give some disclosures. I'm a PhD doctor, not a medical doctor, so I don't want anything that I say to be construed as medical advice or the practice of medicine. I am simply reporting the science behind what we do in biologics, presenting data that has been published, both basic science and clinical data, and reflecting anecdotal evidence that has been reported over my numerous years in this field. As a consultant, I've worked for a number of these biologics companies that develop different devices and products for autologous biologics. So I've been around the field for a while. I'm pretty familiar with what's out there and the good, the bad, and the ugly. So I've got a little bit of a unique perspective on what's out there. And this presentation, though, is completely product and technology agnostic. So the principles that we talk about with PRP and other types of cell therapy are true no matter which system you use, considering if it's an apples to apples comparison and it's the same makeup and composition of the biologic. So the place we start was with the title, and it was an interesting suggestion to talk about what is good PRP. Like any topic, you have to decide, what does good mean? And especially as it relates to platelet-rich plasma, which is what PRP stands for. And we have to first define what is PRP and what's our clinical objective. How can we meet that objective? And then we can decide what is a good PRP to get the outcomes that we want. So the definition of platelet-rich plasma is simply an elevation of platelet counts higher than what is in the natural baseline of the patient's circulating whole blood. If you enrich at all, it is technically PRP. Now, the Gen 1 product that's been around for probably 20 years was an enrichment of what we call the Buffy code. It's a mixture of platelets and white blood cells. You would get 5 to 10 or sometimes even higher fold enrichment above the baseline counts. Because it included most of the white blood cells, there was a lot of pro-inflammatory agents. So you'd see a spike in inflammation or a flare-up after that kind of injection. But it proved very effective in a lot of chronic tendon and muscle injuries. However, it was less effective in some of the degenerative arthritic applications. Along came generation 2, maybe somewhere 5 to 7 years ago, which was introduced a PRP that had reduced white blood cells, so less of the multinucleated inflammatory white blood cells, a little bit more anabolic and anti-inflammatory of a composition, and possibly better used in these degenerative conditions, including joint and disc disease. It's important to understand the cellularity of PRP. I always like to point out it is not a stem cell therapy. Some people get the wrong idea and they like to throw that term stem cell around. As scientists, we're not even clear on what the definition of a stem cell is. But one thing I can tell you is that the PRP is not a stem cell. It is an enrichment of platelets and possibly other things that were in the peripheral blood. So platelets are these little dead sacs full of growth factors. They're proliferative, they're angiogenic, they help stimulate the blood vessels and blood flow in that injured area. They feed the cells, they recruit other cells in. There is some level of white blood cells within a PRP preparation. The mononuclear cells, a lot of them have an immunomodulatory role, so they can actually be anti-inflammatory depending on the stage of the injury and the healing cascade, whereas the multi or polynucleated white blood cells these are more like your granulocytes and macrophages. These are very inflammatory in nature. So they feed on the inflammation and the other condition, the biochemical conditions of a musculoskeletal painful injury, and sometimes they can make it worse. Other times the inflammation is useful. We'll talk more about that later. The last factor to think about is proteins and cytokines. We've got a lot of cytokines and growth factors coming out of these platelets. We also have a lot of cytokines and different proteins that are dissolved and soluble in the plasma, the platelet-poor plasma. And they have a lot of useful functions in regenerative medicine. PRP is prepared through density separation. And basically that just means we're using a centrifuge and we're relying on gravity to separate out all the different components based on how dense or heavy they are. The red blood cells are the heaviest. They sink to the bottom of our tube or our apparatus. The multinucleated white blood cells are the next heavy, so they're going to sit right on top of that. The mononuclear white blood cells sit on top of them. The platelets sit on top of that, and then we have about 50% of the volume, which is platelet-poor plasma, and it should be relatively acellular. However, all of these cell types, depending on the maturity of the cell, they have a range in density. So there's an overlap between these different cell types. That's why it's exceedingly difficult to try to capture 100% of the platelets while excluding 100% of the white blood cells. If somebody tells you they can do that reliably, I would really be interested in learning how they do that, because from a density perspective, scientifically, that seems nearly impossible to accomplish. And what you can do is catch most of the platelets and eliminate most of the white blood cells, but you can't do both completely perfectly. You can do a very effective job of catching almost all the platelets and removing almost all the red blood cells because there's a greater difference in the density of those. The top schematic in this drawing about centrifuging blood, or it applies to bone marrow aspirate as well, relied on a relatively hard G-force spin for 10 or 15 minutes. And it packed those white blood cells and platelets together very, very tightly, and so you could collect them all at once. But because it was a leukocyte-rich PRP, had a lot of white blood cells in it, including those multinucleated white blood cells, it was more inflammatory in nature. And as we mentioned before, in Gen 2, we said, how do we make a PRP that doesn't have so many of all those white blood cells that we don't necessarily want all of the time? And so there were different strategies that were presented and have been commercialized. One is to centrifuge it twice. And so we might spin it at a significantly less G force and or time, so that the platelets don't completely pack down, and then we can take that top fraction and spin it again and then pack just the platelets, and then we get what we want, mostly platelets, not many white blood cells, almost no red blood cells. Some people will take that suspension of platelet plasma and then run it through some kind of filtration to dehydrate it and concentrate the platelets down to a usable volume. There are other approaches as well, or devices on the market. Here in the next slide, it kind of highlights that even within that fine buffy coat of the different cells, based on the densities, there is a very fine separation on the microscopic scale. But a lot of the devices on the market do have the ability to start collecting at the platelets and continue collecting on their way down to the point where you want to cut it off. And so you're going to get the platelets first, then you're going to get mononuclear white blood cells, and then you're going to get multinucleated white blood cells. I have to emphasize that we're talking about PRP. If this was a bone marrow conversation, we would want as many white blood cells as possible, because those stem cells live in the white blood cell layer, and the whole point of doing bone marrow is to maximize stem cells. So I don't want any confusion on that talking point. But when we're spending blood to make PRP, it's just a matter of this question: where do you want to cut your deck? When we centrifuge blood and bone marrow aspirate, this is just a ballpark range of where you start in the whole blood or the BMA, and after you centrifuge it, what would you end up with? And you expect to see a significant enrichment in those things you were looking for. And then in the case of a leukocyte poor PRP, you'd like to see no enrichment or even a depletion of white blood cells, certainly the multinucleated white blood cells. When we centrifuge, we do not concentrate plasma proteins. That's another thing that's very important to understand. Proteins are tiny compared to even a platelet, which is the smallest cellular component. And when we centrifuge, that range will not cause proteins in fluid to consolidate. You would need an ultra centrifuge that is large and spins at hundreds of thousands of Gs in order to concentrate proteins. Or you would have to use some kind of lyophilization, cryo-freezing, and dehydration to concentrate proteins. We don't do that from a benchtop centrifuge. Now, what we can do is use some kind of filtration to remove water from plasma and concentrate proteins, but that's another topic, just food for thought. The evolution of injection therapies for degenerative or arthritic conditions and MSK, many of you would be familiar with the earliest approaches like dry needling or prolotherapy. It's almost like acupuncture in a way, and we're causing little micro injuries with the needling, and those signals that release cause a response. They're recruiting cells in, they're activating local cells, maybe some blood vessels and capillaries get damaged, maybe some platelets are activated. You're getting a little bit of that. At some point, the use of steroids became very popular. Now, I am definitely in the club of the fewer the steroid injections, the better. And if it can be zero, that's great, because we do understand that they are chondrotoxic, and repeated steroid injections are killing the chondrocytes and the cartilage in the disc. So we do not want to have repeated steroid injections. But it was part of this evolution where we can knock down inflammation, and in some percentage of the time, people are able to recover after that one steroid shot. So in those situations, good. The Gen 1 PRP came out, and it was both pro-inflammatory and anti-inflammatory at the same time, because there was these different types of cells that we've discussed, and there's catabolic and anabolic factors in the PRP working simultaneously. It really is a harmony or a symphony of these different elements in our biology that are working to try to supercharge what a natural injury state would be. It worked very good in some situations, like muscle and tendon injuries. It seemed to flare up and sometimes make the situation worse in avascular tissues like joints and discs. The leukocyte poor tried to get around that by taking away some of the inflammatory cells. And then the top of the pyramid is to use a stem cell based therapy, such as bone marrow concentrate, where you get everything you would get in PRP plus the stem cells, which are live actors on the site. So they're like the maestro of the symphony, telling everything else what to do, responding in real time, and sending out new signals. PRP is one level below that, because we are already giving a predetermined dose of different signals out, regardless of the injury and regardless of how fast it heals. What is the dose effect of PRP? We don't really have a good clinical dose effect. It's not nearly as defined as the work of Hernigo and others in MSC therapy and bone marrow concentrate therapy. We rely on a lot of in vitro data. It says things like you want to try to be somewhere in that 5 to 10x range above baseline. Sometimes it was reported that if you got up to 15x above baseline or higher, it could actually impede cell proliferation. Now, that is in vitro. We don't know if that has any effect at all in vivo. It's just, again, something to think about. It's probably unnecessary to try to get to 15x or 20x, and who knows, it could potentially be a negative impact to the therapy. PRP by the different clinical indications. I'll try to just run through this quickly because the MDs will speak about this better than I will. Tendon was the earliest application. It worked phenomenally. This was leukocyte-rich PRP, by the way. So you shoot people up with the inflammatory PRP. Ow, it hurts like heck for a few days, but it starts to get better. It gives you the healing response that the patient did not get at the time of their original injury. It has by far the greatest number of published human clinical trials and positive, statistically significant outcomes. In hip osteoarthritis, um, there's not as much. It compares favorably over hyaluronic acid, if that means much for you. It's not as potent as a stem cell therapy would be, but it does have benefits, and albeit maybe short term, it's something definitely worth considering. And a lot of times in hip OA, the patient doesn't have a lot of options, so PRP is not an unreasonable thing to think about. In degenerative discs, there have been a number of studies in the last 3 to 4 years showing positive outcomes with intradiscal PRP. Again, it's not as potent as a stem cell therapy like BMC would be, but especially for early onset DDD and especially in younger patients, there seems to be a pretty good response. And according to Dr. Lutz and others that have published multiple times on this, there doesn't seem to be a clear effect of the leukocyte rich versus the poor. So the rich might flare up and give more pain in the short term. Whether the long-term impact of that is understood, I don't believe so. We don't know which is better. In meniscal repair, it's kind of like the approach of surgery. When it's a red on red tear, you're like, yeah, it's probably going to heal, and PRP will probably accelerate that healing. A red on white tear, very similar. You may get healing, and PRP could help whatever the prognosis would have been without a biologic. If it's a white on white tear and there's no stem cells in PRP, it's not likely you're going to see any kind of anatomical or structural repair from a biologic injection alone. And honestly, even a red white, maybe even a red red, you wouldn't see any healing from a biologic alone. But with a lot of nuanced technology, like being able to deliver biologics in the office setting and delivering it as like a fibrin glue, for example, you might be able to glue a biologic into a tear, let the glue serve also as a scaffold to hold that biologic in and direct new tissue growth. And perhaps in the future, we will be seeing real tissue regeneration without the need for surgery. There is no statistically significant clinical data that supports PRP infusions in the spine or non-union trauma, avascular necrosis, like that femoral head that we were talking about earlier in the hip OA, the intraosseous bony necrosis. A PRP injection is probably not going to reverse that. Articular cartilage, when it goes, PRP can help the effects of the osteoarthritis, but it doesn't repair the cartilage. Ligament tears, very similarly, it's avascular. I'm sorry, it's you don't have a reservoir of regenerative cells as an adult, so the PRP is not providing what you need to repair a ligament or the meniscus tears that are associated with an ACL tear. So back to our question, what is good PRP? And we've talked about leukocyte rich and leukocyte poor, and I have a little cartoon here where the leukocyte rich is red because there's usually more red blood cells in it. It'll come out a red or an orange color versus leukocyte poor, which is a yellow or golden or maybe amber color. Leukocyte poor, because you're trying to exclude white blood cells, typically has less platelets. That means it has less growth factors, but it also has less inflammation. So it all depends on what you're doing clinically, what your goal is, if this is going to work or not. Degenerative disc disease affects roughly 30 million. Supposedly degenerative joint disease is very similar in that it also affects around 30 million Americans annually. And what's funny is that there's so many underlying similarities. They really are analogous to each other. We have osteonecrosis and damage to the cartilage at that bone cartilage interface. We get dehydration of the proteoglycans in that cartilage layer. We get a buildup of acidic and other inflammatory molecules in the tissue, and these MMPs come in and start, so matrix metalloproteinases, these enzymes that in a degenerative state cleave and break up cartilage and lead to further dehydration. It just becomes a toxic environment, and without some kind of resident fibroblast or stem cell population to be able to come in and work to reverse that damage, we're not going to see that as just a part of the natural degeneration, whether it was trauma or age related. Over time, once it goes, it's just a progression. And so how do we slow that down, or is it possible to even reverse it, especially in the context of using biologics? In the soft tissue, we're beating the nail over the head here, but leukocyte-rich PRP has a lot more data supporting it in soft tissue than leukocyte-poor. I'm sure the patient's going to say, "Ow, hurts," but long term, they're probably going to do better, or at least that's what the data would support today. Does that mean leukocyte-poor PRP doesn't work? Absolutely not. It could work great. It could work better for some people. The patients might not call you the next day and complain as much. Are they going to have better long-term results? Maybe. But the data right now is stronger with the leukocyte-rich. This paper has been around for a couple of years, but it has been bounced around a little bit on social media blogs related to biologics recently. And I thought it was funny when they're advocating save the meniscus, and they were showing how when surgeons go in and they shave or repair or whatever they want to call, and when they arthroscope the meniscus, these people don't do better than non-surgical or non-operative, less invasive treatments, including PRP injections. So why would you go do something that is irreversible to the patient and their injury, i.e. a surgical intervention, when you could do something like regenerative medicine, where the worst thing that can happen is they don't get pain relief, but all the other options for them are still on the table. If someone goes and has a spinal fusion or has their meniscus cut out, that is an irreversible decision. And if they don't like the result, they're in a tough place with not a lot of other options. Intra-articular injections, we've already discussed that leukocyte-rich is more inflammatory, so it is very likely that a leukocyte-poor PRP would probably, will certainly have better short-term results and could even have better long-term results. And in the spine, we discussed this as well. It's unclear which type of PRP has better long-term results. Both seem to be favorable as long as the most appropriate patient population is what's being treated here. People with very severe degenerative disc disease, very black disc, flat disc, they are probably not candidates for a PRP injection in the disc. There's a number of papers that support the use of epidural PRP and neuraxial PRP. I'm not going to spend much time discussing it all. Just to say that there's been a very positive pain reduction response in these applications. And for the question of, is it safe to inject PRP anywhere near a nerve or a spinal cord? Well, the counter back to that is always, blood patches have been around for a long time, and that's an injection of whole blood. So is this any different? We're just taking a subset of the blood and injecting that. So in my opinion, the answer is no. It's just as safe as doing a blood patch. Another study with the epidurals and the neuraxial PRP. We must always consider both the biochemical and the anatomical environment. What that means is, when we're picking our biologic, what is the anatomy? Is it vascular or not? Based on the patient's age and their health, do you expect that they have a good healing response on their own? If the answer is no, you're going to need a bigger boost, or maybe a regenerative therapy isn't an option for them. So, like prolotherapy or something like that is the lowest level. And then you have a PRP type therapy. Somewhere in there, we might have a discussion about amniotic type therapies. If it's a well-defined amniotic birth neonatal tissue, But that's a whole different conversation. And then there's regulatory implications with that as well. And then at the top, a stem cell therapy like bone marrow concentrate would be the most potent. So we have to consider the anatomy, also the anatomy as it relates to what is the injury, how bad is it, does it require some kind of mechanical fixation, i.e. a surgical intervention in addition to the biologic, or would an injection only be appropriate? And then what is the biochemical environment at the same time? Because we understand the pro-inflammatory factors like interleukin 1, TNF alpha, these enzymes called MMPs, and what they're doing. And at the same time, we're going to counter that with these anti-inflammatory or anabolic factors that are coming from the platelets and the plasma. That also includes proteins like IRAP, which is interleukin 1 receptor antagonist protein. This was the thing called orthokine or regenokine that was so popular a few years ago when NBA and NFL players were flying to Europe and paying tens of thousands of dollars for this magic injection, which was basically their own blood activated with glass beads, and the plasma was injected back into their joint because the cells responded to the glass beads and produced more IRAP protein, and that IRAP binds up interleukin 1. And so you don't have the same pain response for as long as that IRAP protein is present in the joint. Alpha-2 macroglobulin, or A2M, is a potent protease inhibitor. It's synthesized in the liver, but it's present in high levels in platelet-poor plasma. And so the plasma part of our PRP, or our bone marrow concentrate, it contains A2M, which binds up the MMPs. It binds up a lot of the other inflammatory cytokines as well. And so that also is contributing to the short-term pain, or immediate pain relief in a degenerative type injection with PRP. So here we go. What is good? What is bad? These are the elements that are in blood or in a PRP as well. Platelets. Our target, we're trying to get somewhere in there. Here I have 4 to 8x, 5 to 10x is all of this range is kind of what we're talking about. And it's somewhere between 1 and 1.5 billion platelets per milliliter is that concentration that we hope to achieve. In vitro data says it's good. It's not necessarily better with more, but at some point it may be too much. But do we want it? Yes, absolutely. The lower inflammatory white blood cells, we're not looking to shoot the moon and get 20x enrichment of those things. Do they contribute? Yeah, a lot of them support immunomodulation. A lot of T cells specifically are very helpful in driving that healing cascade forward to the next stage. And so having some of those present could be very beneficial. So I think a lot of the times in these MSK applications, yes, we do want to have them. The higher inflammatory multinucleated white blood cells, that's next. What's our target? Well, those degenerative avascular joint spine tissues, well, we probably don't want them. So we'll try to keep it at or below what the baseline is. In a muscle tendon, that's what's been proven most often to work. So yeah, we probably do want them. And the answer is, so are they bad? I don't know. Is the inflammatory signal a good thing? Sometimes it is. We're going to get better long-term healing from sending out that inflammation. No pain, no gain, right? So sometimes we do want it. Sometimes we don't want it. It's of no use. It's just pain for the sake of pain. Plasma soluble factors like IRAP and A2M, they are absolutely great. The more extra volume a joint can take, you should go ahead and put more platelet-poor plasma in my scientific opinion. The more of these proteins we get in there, the more pain relief the patient's going to have ultimately. We can't obviously inject 30 cc's of plasma into a joint. But once again, it kind of comes around to, can we use like a filtration process to take 30 cc's of plasma and reduce it to 5 cc's or less of a protein concentrate that you could inject with your PRP and then get all that A2M and IRAP. So that is a very good thing, in my opinion, all the time. Do we want it? Yes, absolutely, we want that. Red blood cells, For a while, there was a bad hit out there on the market. Red blood cells is bad. That narrative is almost always coming from somebody who was trying to sell a sophisticated two-spin type PRP device because they said, look, our PRP doesn't look red. Everyone else's looks red. We're good. They're bad. Buy our product. There isn't any credible in vitro human data that suggests that a red blood cell does anything negative in a regenerative perspective, or to prevent the reversal of a degenerative condition. Now, what it does do is it takes up volume. And if a joint can only hold 1 cc or 5 cc's or 10 cc's, we want to reduce the amount of that is red blood cells, because it's taking up space that could be something else that we know is good. So if you have a choice, would you want more plasma or more red blood cells? The answer is more plasma. Plasma we know is good. Red blood cells we don't know to have any good value. So do we want it? No. Good versus bad PRP. There we are, the subject of the talk. And it all comes down to, what is your objective? Because if we're trying to get very short-term pain relief, a lot of times the answer is going to be, you use leukocyte poor PRP. The patient's not going to call your office the next day complaining about how much more they hurt after they paid cash for a procedure. But if you have that conversation with your patients and say, look, we're not going for you to feel better 2 days from now. We want you to feel better 2 weeks from now, 2 months from now, maybe a year or more from now, if we do this the right way. And so a lot of times a leukocyte-rich PRP may be a better preparation, or maybe it's somewhere in between where it has more of the mononuclear white blood cells and less of the multinucleated white blood cells. And that's still up to the clinical field and science to prove out what is the ideal concoction for every type of injury. We don't know that yet. At this point, it really is up to your best clinical judgment, which is the most appropriate PRP to use. So by indication, if I can summarize it in one table in a osteoarthritis type environment, the immediate response, if the leukocyte poor PRP, is anti-inflammatory, most likely due to that IRAP and A2M. Leukocyte rich PRP, the inflammatory factors will probably outweigh the anti-inflammatory factors in the first few days. So you're going to have inflammation. In the near term, say a week or two, the leukocyte poor, the patient's still going to have some relief. Anecdotally, there's a lot of, and published data, there's a lot of variation with the leukocyte rich. The long-term results, I don't think that there is anything conclusive about the leukocyte rich versus leukocyte poor in a long-term follow-up, say 12 months or beyond 12 months. So don't have a great answer for you there. Soft tissue injuries, particularly tendon, muscle type things that are chronic, leukocyte poor isn't used as much, but is used quite a bit, and there's varied results. I don't know that there's ever an anti-inflammatory right off the bat with the tendon injection. Leukocyte rich certainly is inflammatory. It's going to hurt. It's going to sting. But here we are with that data saying, well, that big sting, that inflammation is sending out signals to those pericytes on nearby capillaries, and pericytes are actually the mesenchymal stem cells, and they're recruiting endothelial cells, and they're recruiting fibroblasts and tenocytes and chondrocytes, and we're building up matrix and we're repairing the tissue. So in these situations, it seems like that inflammation is of value, and we feel a little bit more strongly data-wise about the leukocyte rich. In degenerative disc, being honest, like most patients, when you inflate the flat tire, they're going to be in a lot of discomfort for a few days, regardless of which biologic you use. It's possible that leukocyte rich has more inflammation and more pain, but I think the leukocyte poor also, at least anecdotally, has a lot of pain associated with it in the short term as well. That near term response of a few weeks for PRP in degenerative disc, it seems that there's a lot of influence on the age of the patient and how far along that degenerative disc disease has progressed. Long term, we still don't have the data to say, is this effect going to be beneficial for more than a year? But again, as we said, regenerative medicine is an option. It's another tool in the toolbox. It's something to present to that patient because a lot of times they don't have very many good options. Do they want to go the opiate route? We hope not. Do they want to go the surgical route? We hope not if they can avoid it. And this is something else that's worth trying. So basically, bad PRP is when you use an inappropriate combination of all these different factors based on the injury and the patient in front of you versus the opposite. A good PRP is when you use the most appropriate combination of all these different cellular and protein components as dictated by the injury, the anatomy, and the anticipated biochemical response of the injury state to what biologic it is that you're choosing. I wanted to have a couple slides about the future just to say that I think that we are in desperate need of a correlation between the platelet dose effect, how many platelets we deliver, and the outcomes. We're still not there yet, but I think in another 5 years, we are going to have some good data about this to really drive home what the best ratios are of platelets and white blood cells and other proteins for different clinical indications, and which of the cells we should exclude for sure, which ones we don't care about, which we should enrich, and how and which of the plasma proteins do we want to tease out and deliver that with our cells. And I wholeheartedly believe that at some point in the future, it will become a prerequisite to surgery in a lot of situations. If it's a chronic degenerative MSK injury, why would we not want patients to try a therapy where 50% of the people get significant results? And financially doesn't make sense. How we approach medicine, it doesn't, and trying to do best by the patient, it doesn't make sense not to try this first. So at some point, all the third-party payers, I believe, will get on once they see the financial incentive to them, because it's a cheaper route than surgery for them, and it's going to keep a lot of these patients out of ORs. In conclusion, we can personalize the regenerative medicine biologic based on how we centrifuge and separate the different cellular components and protein components in blood. We have a target of somewhere in the range of 5 to 10x above baseline, or 1 to 1.5 billion platelets per milliliter. In vitro data says we don't want to get up there 20x or higher. White blood cells, it all depends on what you're doing clinically, what kind of injury you're treating, if you want them and which ones you want. And in the future, we'll be able to more closely define the dose of each for every kind of patient demographic and clinical indication. I want to thank you all as an audience for your attention. I look forward to any questions you may have, and thanks to the organizers once again for the invitation to speak here today.